All right. Hello, everyone. Thank you for joining us. I'm Dr. Brandon VanderWel. This is the Eviva Weight Loss Treatment Options Seminar. And today we're going to talk about all the different options that are available to people that are struggling with their weight. And that is a lot of people. So 40% of the population of the United States, in fact. So who are we? This is our practice, Eviva. We've been leaders in bariatric surgery and innovators there for almost 20 years now. First in the Pacific Northwest to do a laparoscopic sleeve, first in the world to do an outpatient laparoscopic sleeve and an outpatient gastric bypass. Done a lot of papers. We're the first in the Pacific Northwest to do an endoscopic sleeve, the gastroplasty, the ESG. And yeah, it's been a great journey. We have a great team, two bariatric surgeons, myself and Dr. Landerholm, bariatrician, nurse practitioner. We have two dietitians and two surgery PAs. This team is great. I love working with these guys. They are they really care. They're experts in their field, and they love helping you. And that's why we come to work every day, and that's why we love the job that we have. We get together on a regular basis, discuss all the things that are going on, how we can make things better. If people are struggling, what are some different ideas of how we can help them? And it's just a great brain trust, and I love working with these people. And all of our support staff at Eviva, they're fantastic. Saw a bunch of patients today, and they were all just had great things to say about the staff that they've interacted with. So let's take a look at obesity from a 30,000 foot view. Why is it so hard to lose weight? And when you step back and take a look at it, our bodies are really not made to live in the 21st century. Your genetics don't believe that comfort and abundance is a thing that you're experiencing. It is built to survive hardship and scarcity. You think about even just 100 years ago, and that's nothing in the terms of biology. 100 years ago, your living conditions were very hard. They were small, they were not climate controlled. Your jobs, all the work that we did was a lot more intense, labor intensive. It was difficult. It was, out in the elements. It was hard. It was long. Transportation was very difficult and very uncomfortable. You couldn't go very fast. You were, still subject a lot to the elements. It took a lot more calories than it does now. Now our cars practically drive themselves. You're spending like 10 calories while you're going even long distances in some of these cases. And the food that we eat is totally different as well. The way we get our food, the way we store our food, the way that we make our food is just completely different. You just think about now, if you want to eat some pasta, you just go to grab a big box and make it. Before you'd have to like ground the flour, press the dough, cut it up. Like the process of getting food, storing food is completely different. All of these things are a setup to go in the direction of making it more difficult to manage your weight. Our bodies really don't think you're going to survive the winter, and they want to save and conserve as much energy as possible because life is hard. And we got a lot of problems in the 21st century still, but refrigerators in Costco and sedentary lives with climate controlled houses and jobs and cars that drive themselves have made it much, much more difficult to manage our weight. I break obesity into 6 things. It's the way I approach obesity: mindset, diet, exercise, psychology, support on this hand, biology on this one. And biology is king. If your biology is struggling with obesity, it doesn't matter what you do on this hand, you are fighting this uphill battle against your body. These tools we're going to talk about, these are tools to help us with this. We all work on this stuff too. All of us have a room for improvement here. But we're going to talk about tools that really help with the biology piece to really change that uphill battle into a downhill battle. So you start working with your body as opposed to against your body. So many of you have heard and have been told that you just need to eat less and exercise more. You need to try harder. Remember the show The Biggest Loser, where they put people through that really struggle with their weight. They put them through, intense exercise and very strict diets. Gained, lost a bunch of weight on a TV show. Most of those people gain their weight back, and most of those people go on to do surgery. Done surgery on some of them. And this is the mantra that it is really only works for about 5% of people, unfortunately. So, with that being the case, what are the other tools we need to do? Because effective, like saying eat less and exercise more, is not an effective public health intervention. We need to do something else in the 21st century. Diet and exercise, like we just talked about. Sufficient weight loss is, generally not very good. On average, it's 5%. And then 5% of those people are getting, significant weight loss and are able to maintain it. But the durability is very difficult. It's for most people that are turning into this have experienced the weight yo-yo. You lose some weight, you gain it back, gain back more. And you just keep going on this cycle for years, decades. And it's really, really frustrating. It's really difficult because you're fighting that biology. Complications aren't not a lot of complications, just frustrating and disappointing. So let's talk about, next thing we're going to talk about is medications. So this has been a really exciting field in the last several years. I'm going to break it up into kind of traditional tablet form medications and injectable medications like the GLP-1s, like semaglutide, ozempic, mounjaro. So the non-injectable medications, so this is like phentermine, naltrexone, Wellbutrin. There's a bunch of other things that we use for weight loss. Their weight loss is about 5 to 10% on average, which is not bad, not terrible. Durability is okay, generally as long as people, if they come off of those medications, it does get harder to maintain it because that's a tool that only works as well as long as you're taking it. You can build in some healthy routines on this hand that really sets you up for success for long term. But that biology piece, when it's taken away, the medication is taken away, it is more challenging. There can be medication side effects. That can be anything from like hypertension or tachycardia or anxiety or sleeplessness to, not feeling good, any number of things that can happen when you take some of these medications. They are mild. Side effects are common, but it's not like everyone's getting it or has to stop it. But we do watch it carefully. That's why these are medications that we have very close follow-up on initially, just to make sure that you're tolerating well. Weight loss is okay, like we talked about, and it's slow. It's on the slower side, which is okay. Sometimes helps it be more sustainable for some people. So let's talk about kind of the newest kid on the block, probably the most exciting thing that's happened in bariatrics in a while, and that is the GLP-1 receptor agonist drugs. So these are the injectable drugs. I'm sure your social media feeds are blowing up with this. They've been pushed hard the last couple of years. This is semaglutide, which is the generic name. Brand names are like Ozempic and Wegovy, and Mounjaro is a little bit different version of this, which is GLP-1 plus GIP. These medications have shown some really exciting results. We're seeing 10, 15, sometimes close to 20% total body weight loss for some of these drugs in some of these trials now. Those are great numbers. We haven't seen those numbers from a medication, really in a long time. And even fen, which was, considerably more, we found out was much more dangerous, was getting not even quite this good of results on average. Durability though the results so far that the durability after you stop the medication is really hit or miss. These drugs are big guns. So GLP-1 is a hormone that your body naturally produces. It decreases, your central nervous system's appetite drive. It also does gut hormone changes, acting to slow down your intestinal motility and also to slow down particularly your stomach emptying. These are real tools on your biology, and those things are doing something. And when you take them away, your body is like, well, can actually go into withdrawal. We have protocols to wean people off of these so that they can get the most sustainable success with these drugs. These drugs also really can induce a very, very much decrease people's appetite in ways we haven't really seen since surgery. Because of that, if you're using one of these medications or thinking about doing one of these medications, you need to do this in a safe way. And by safe, I mean you need to have, a nutritional plan watching you to make sure that you're not just losing fat and muscle. When you're losing lean body mass, you're going to decrease your metabolism. It's going to actually be worse off than when you started this process. And when the medication goes away, this has been seen in the data that you can gain more weight than before, and it's actually more fat than you had, and you actually have more fat on you than you had before. So doing this medication these are exciting medications. We've seen some great success with patients We have ways of, of trying to make this affordable for patients as well. They can be very expensive, but I can't stress enough that these are pretty big guns, and they need to be done with experts, and to have really good support and follow up, and the support that you need to really set yourself up for success for, number one, getting the most weight loss, and number two, being able to sustain that weight loss in a real fashion long term, and that you're getting healthy weight loss. Their downsides are that their GI symptoms are common. So usually we titrate up till honestly you can't tolerate them, and that's usually there's nausea. Sometimes there's abdominal or intestinal things like diarrhea. Some people just don't feel very good on them. Some people describe it as morning sickness, and that's generally dose dependent. The doses that we are using these medications, they are natural hormone in your body, but they are at several times, not quite an order of magnitude, but like 5x times what your body usually sees. So it's a heavy gun on some of that stuff, but we're seeing some good exciting results. Downsides is that they're expensive and they can be hard to get and find. They're very popular right now, which is cool, because there's 140 million plus people in this country that struggle with obesity. So it's really cool that we have something that's much more approachable for patients, but it can be very expensive right now. We have ways of trying to make sure that the cost is, there's coupons. We have other ways that we work with patients to really try to be this as affordable as possible. And yeah, but they're good tools. But the weight regain is a thing when people stop them, especially if they stop them cold turkey. So we have a process to taper patients, and we watch that carefully to make sure that you are able to maintain your success as much as possible. So that's kind of our medication section right there. Now we're going to move on to the procedures, into the procedure world. The next one of that, there's my semaglutide, tirzepatide, that's Mounjaro. Endoscopic sleeve gastroplasty. So this is the ESG, the endo sleeve. This is technically a non-surgical weight loss procedure, which is very exciting. There's no incisions, nothing's completely removed from your body, which is what really appeals to a lot of patients. Its recovery time is much quicker than surgery. It's done using this Apollo overstitch device. That's this. It goes on the end of an endoscope, and is able to allow us to suture. It goes down through your mouth and into your stomach, and your stomach, which is this big bag, it takes small bites of there and then crumples it down into a small sleeve-like shape. Take full thickness bites of that stomach so that it's good, solid, durable sutures in a pattern that allows us to continually crumple down that stomach. And we're seeing some exciting results with this. We're publishing a paper right now, seeing 23% total body weight loss on average, which is very good for something that's not surgery. There's nothing else like it when it comes to something that's not surgery. We're getting better results than the lap band did. Certainly better than the intragastric balloons. We are getting better results than our GLP-1s. So yeah, this is a really cool tool. Its durability is really good because you're using permanent sutures inside of your stomach here to really crumple it down and make it much smaller. Well-placed sutures are going to stay in the stomach 90% of the time long term if you take care of that tool. Complications are very rare, which is great. It is endoscopic, so you're working inside this space, but our tools are limited, so there's less things that we can have issues with. Our complication rate is very good. It's less than 1%, it's 0.7%. And the complications that we've all had have all been very mild. Like one patient's needed to have a little, it had a cramp, had to get dilated, and a couple of blood clots that are manageable with some medication if needed at all. So these are exciting tools. These have been really cool. The downside, I'd say, is that it's self-pay right now. It's not covered by insurance, so it can be a little bit less affordable for some patients, but this is still considerably cheaper than a bathroom remodel. Limited long-term data. So we have one 3-year paper from a practice that has 3,000 patients in it that shows durable results. One 5-year paper that shows durable results. We have been doing ESGs for over 3 years with hundreds of patients, and we're seeing some good durable results as well. But it's not like we have 10 years of data like we do with the other surgeries. The recovery time is about 4 to 7 days. I usually tell people this is like having a stomach ache for about 2 to 4 days is what it's kind of like. And you just feel like, whoa, I don't feel that good. It's not, most people don't describe it as like pain, like, oh, I'm sore right here. It's like, bleh, I'm just kind of like, my stomach got tightened up because that's what happened. And then one morning you wake up and you're like, oh, yeah, I feel way better now. So that's cool. Yeah, and then we have very very clear description of what we want you to do from a portion size standpoint, from a calorie standpoint, from protein, carbs, and we build a whole nutrition plan for you after these procedures. I think the follow up on this procedure, particularly as well as the surgeries and the GLP-1s, like I said before, is very important for getting the most out of this tool to get the best success and also to set yourself up for maintaining that success long term. So now we're going to go into actual surgery. So this is laparoscopic bariatric surgery, which is using incisions and a camera, and that we're able to see on a screen, and small instruments that are about this big. Got this guy right here. This is the stapler, where you are able to use the space inside of the abdominal cavity to then reduce the size of the stomach, which is that big bag again, from that big bag down to a small tube, and you remove the extra stomach for a laparoscopic sleeve. The way that's done is with this stapler device. You can see here, and you can see what that does is it actually clamps down on the tissue like this, and then all those little dots, all those little holes in there, they're tiny little staples, like 2 to 3 millimeters in size, makes a layer all the way around there, and then cuts in between it. So it's a very nice, a very clean, precise way to do a surgery. It's a beautiful way to do surgery, honestly. And you can see here in this picture, this is where the surgeon has the stapler, and they are slow. They're marching up the stomach and just honestly just making it smaller, making it a sleeve shape, and that extra stomach comes out. Patients always ask, like, well, what if I need that stomach later? And I say, this surgery, as well as the endoscopic sleeve, really what we're doing is we're giving you a 21st century stomach. In the 21st century, when we have refrigerators in Costco, we don't need stomachs this big. And I firmly believe that 90% of the population could have a stomach way smaller and they would do better. That is because our stomachs are so big, they're big capacity organs, so that, think about 500 years ago, you get the gazelle. You need to eat as much of that thing as possible because you don't know how long it's going to stay. The harvest comes due. You need to eat as much of that as possible and store it. Store that food as fat because you don't know how well it's going to keep over the long, over the winter or over the whatever season is coming up next. Food, your body was its own refrigerator, and your stomach needed to be able to eat as much as it possibly could every time you had the option. In the 21st century, we just don't need stomachs this big. We really don't. I have big male patients even that are living their best lives with these small stomachs and being, more active than I am now, like running races and racing motorcycles or cars and, just doing stuff that is very calorically dependent and have no trouble staying on top of their nutritional needs, and they are living their best lives. And that's kind of the most extreme example, and I think everyone under there is like can absolutely make this work. This is the gastric bypass. This is also a relevant operation still. This is the grandfather of bariatric surgery. We don't do as many of these in our practice or in the country just because the laparoscopic sleeve has come along, but it's still a good operation. It's still a relevant operation for patients that have maybe bad heartburn or bad diabetes. It can be a better operation for them than a laparoscopic sleeve. You should talk to your surgeon to see which is going to be the best option for you. This makes a little gastric pouch here. You bring up a piece of small intestine, and then you actually bypass the first part of the stomach, this part of the stomach and the first part of the small intestine. The laparoscopic sleeve, like we mentioned before, it reduces the size of this stomach from this big bag down to this small tube. Durability, these are the best weight loss, 25 to 30% that we see in our practice, and it has the best durability long term. These are all tools. Everything I've talked about so far is a tool. It is not a cure. It's not a magic wand. It's not a silver bullet. There's no such thing that exists in obesity treatment. And I think it's important to have that mindset when you go into this. And whoever's taking care of you should also have that mindset that, hey, these are all just tools. They're not magic wands. And they have strengths and they have weaknesses. The bariatric surgeries are the best tools. They get the most weight loss and they are hands down the most durable. We have the most data on them. And in our hands, honestly, in our practice, we're very safe. We have a surgery center at our place. We also do cases at the hospital, at Evergreen Hospital, Evergreen Health. And our complication rate is excellent. Beats the national average by a long ways. We are one of 16 facilities in the country that have a certificate of excellence for bariatric surgery in an outpatient setting. We were actually one of the, obviously, like we talked about before, founders of the outpatient bariatric surgery. And it's been fantastic from a safety standpoint and from an outcome standpoint. Complications are rare, but they can be, complications of surgery: a leak, a bleed, blood clot, infection. They're very rare in our practice. They're less than 1% again, about 0.6%. But when they do happen, we need to make sure you have a skilled team that has a lot of experience in making sure that we get you through safely. Downside of these surgeries is that it's not always covered by insurance. Some people's insurance does have coverage for bariatric surgery, and it is a case-by-case policy decision based on where you're getting your health insurance from. Recovery time is generally about 10 to 14 days, I recommend, for patients. Some patients need longer, and that is totally understandable, and I support that. Many patients are still back to work to their desk jobs at 7 days. And the recovery is generally fairly smooth. It'll be like, yeah, I'm sore when I move around from those incision spots, but like, hey, I'm chill. I'm getting my fluid in. I'm getting my protein shakes in right now, and they're off to the races over that first month. Their diet progresses. So, how do I take all these? You know what? If you were out there and you're like, I'm struggling. I have tried doing this and I need some help. I don't know which of these I may even want to do, but the first step is just to reach out to our team. So EvivaMD.com, EvivaMD.com /contact us. You can even use this QR code right here, or go to the spot on the website. The way it works, we'll set up, get some information from you to give you all the information about, what does your insurance say? What does it cover? What does it maybe not cover? What's your out of pocket? Do you understand if, from a self-pay standpoint, here's the cost of things. Just make sure you're totally informed when you get set up for your consultation. Get on the schedule. And then usually you meet with us and with our team, with those great group of people before. And we do most of our visits telehealth. If you want to do it in person, you can. But it's very convenient to do telehealth. It is fantastic. We have patients literally from all over the world. We've done surgery on patients from Asia, from Africa, all over the United States, lots of patients in Canada. And we can continue taking care of them. Like, we can continue to do our normal follow-up because we can do all of these things through telehealth. And it has been a fantastic tool for helping patients that are struggling with their weight. Because so much of it is working on all the pieces on this hand, right, to set you up for success, so that we're using that tool to the best of our ability so that it's going to get you the most success we can. At that visit, we're going to review your medical history, your surgery history, talk about, what's been your weight history and what you're looking for. What's sort of your, the surgery is really, really scary, but the endoscopic sleeve, that resonates with me. Or the procedures itself, that's just a little bit too spicy for me. Maybe I'm going to go try to do a medication. And we talk about all those options for you, and we just find the best program that's going to be for you, make a plan for you, and then here we go, and off we go. So, if you're ready to start that journey, not that journey, reach out. And yeah, we love this, taking care of patients. It is incredibly satisfying to see you in your journey and making progress, and not just honestly on the numbers on the scale, but there's so many other things that go along with that, the way you feel about yourself and the way that you're actually able to execute so many other things in your life that you want to. When you can make a plan for something, particularly like your diet and your health, and you start being successful in executing that plan, you feel so empowered. So there's so many great benefits of this, and yeah, we're excited for you to get started. So, all right. Thank you all for tuning in. This is a question that I always get, so I'm going to make sure we address it now, which is, what's the diet like before surgery going into it, and what's the diet like after surgery? So we do a liver shrinking diet before surgery. That's about 2 weeks. It is not a liquid diet in our practice. We have found that to be cruel and unusual punishment. If you want to do a liquid diet, you're welcome to. We're not going to stop you. But what our goal is to be somewhere between 12 and 1600 calories. You'll meet with the nutritionist to give you your goals, and about 40 grams of carbs or less every day. And the goal of that is that we want to have you lose some weight on the run up to surgery. And where we want that weight to come from is around from your liver and around the fat that's around your intestines, because that's the place, those spaces sandwich your stomach. And so if we lose some weight out of there, lose some mass, it gives us more space to do the best and safest surgery we possibly can. After surgery, you're on liquid diet for 7 to 10 days, where you're drinking about, our goal is to get you to 60 fluid ounces, 60 grams of protein. Then we're moving on to a pureed diet for somewhere between 1 to 2 weeks. Then we move on to a mechanical soft diet for about 1 to 2 weeks as well. And then we're moving on to regular texture foods, and we start working with building your menu of what you're going to start looking at long term. And this process of progression usually occurs within a month right after surgery. After surgery, the diet really is lean proteins, some vegetables, and maybe some complex carbs. We want you to measure your food. We have specific portion guidelines from a volumetric standpoint, because if you've had a procedure, you don't want to put too much stress on that stomach to stretch it out over time. And so we also give you goals for calories, for protein, for carbs, for fats. And that way we can help you build this routine and a new menu that's going to really set you up for success for that first year. And if you have a really good routine that you've built, you're going to be set up for success for the next several years. Food that is off limits over time is usually, it takes some time, several months for most patients to tolerate like tough red meat or raw vegetables. And then sticky carbs like sticky rice or sticky bread, we generally try to avoid that because there's not really any very little nutritional benefit to that in general. But it's a great source of energy, but usually that's not the problem when patients are coming to us. So you really want to make sure those are in very small portions. And then the long-term wise is carbonated beverages usually don't sit super well because all those bubbles make big gas bubbles, and there's just not a lot of space in your stomach anymore. But generally, most of the time, people can still eat stuff. They can still have a little bit of treats every once in a while. And we just work with you to make sure that your routine is healthy and that you can still have, some of the things that you enjoy in life. That's not going to change. It's just going to be the portion sizes, the moderation, and the balance and what your routine is normally. And what's interesting about these tools, particularly these last three, the medications, the endoscopic sleeve, the laparoscopic bariatric surgeries, is that you can try to set up that diet ahead of time. We ask this to patients all the time. It's like, okay, you're on this great routine. Could you have done this before surgery or before any of these tools? And it's just like, no. These things really do something on the inside. They really do give you an edge to really help you in the times that we are maintain a healthy lifestyle. So, all right. Well, thank you, everyone. Now we'll go to the live Q&A session, and thank you for tuning in so far. All right. Okay, everybody. Well, thank you for tuning in here. I am Dr. Brandon VanderWel. This is the live Q&A portion of our virtual seminar. Thank you for tuning in. And yeah, now's the time where we address questions. This you're just tuning in or you're watching the pre-recorded version. You're welcome to leave comments in these videos, and we go back and review them and try to address them on our next virtual seminar and Q&A, so you can keep up to date and use these as resources. So, got a couple questions that have come in the meantime. Let's see here. So Chris has a couple questions, and he says, do I need a high BMI for surgery? No, you do not, Chris. So the usual insurance requirements for getting approved for bariatric surgery are BMI 35 with a comorbidity of hypertension, diabetes, bad sleep apnea, and some other ones. These completely depend on the insurance, on your insurance plan, not even just the big insurance provider, the plan that your employer gets from their insurance provider. And then BMI of over 40 is usually covered if the plan covers bariatric surgery. It's not always a guarantee that they do. We have updated our requirements from a society of bariatric and metabolic surgeons. We're trying to really bring these recommendations into the 21st century. And that means having guidelines that are a little bit lower. So usually BMI of 30 with the comorbidity and BMI 35 and above that we recommend for surgery. Most insurance companies in Washington state have not adopted those. So we just figure out what's the inclusion criteria if you have the weight loss surgery benefit, and that's what we get approved. So that's the insurance piece aside. Insurance approval for bariatric surgery usually requires a higher BMI or BMI with a high BMI with certain criteria. If patients self-pay for their laparoscopic sleeve, their gastric bypass, their endoscopic sleeve gastroplasty, the criteria for that are very different. They're very much more personalized, and I think that's where we do offer surgery and these procedures to patients in lower BMI, even below 30. Usually my criteria for patients is if they are 35 to 40 pounds above their adult historical weight and they're really struggling to lose weight. Even if they're below BMI 30, we have a conversation about whether they qualify or not. We've been doing that for years and years and decades plus, and have had a lot of really successful patients with that. And patients that are really pleased that it's just really gotten them that extra bit because, I mean, especially if you're a smaller framed woman, like that's 100, should be 110, 115, 120, 25 pounds. You're carrying an extra 40 pounds. That's very uncomfortable. It's a very significant portion of your body weight that your frame doesn't really want to cover. Carrie, so we've seen great success for patients with those tools. In a little bit, not quite exactly your question, Chris, but the GLP-1 medications have become a really good tool for those patients too. I mean, you probably have seen them blow up in your feeds and they're all over the place. I mean, right, celebrities are using these drugs a ton. And they can really help that weight loss for people of all sorts of BMI criteria. It's a really cool tool for that. We do that with patients. The cost, it's usually not covered by your insurance if we do that, but we do work on finding the most affordable ways to cover that. We don't sell the drugs, which makes it a lot cheaper for patients to get it from us because you just pay for the provider. And we try to find and source our drugs from, if we don't get the brand name, we get compounding ones that we've determined, we've been using for a while and we think are safe and things like that. We have that whole conversation. But to get you that the most affordable way you can and get the help you can. With everything, there's pluses and minuses. GLP-1s are great for many patients. They're not always, I think it's important to know that their success rate isn't even as much as there is with surgery as far as getting to people getting the weight that they want off. A lot of times people stall out considerably before they would with a procedure. And then it can be hard to maintain that after you stop. And they can be expensive. So it's a journey. And for us, the most important thing is just finding out what's going to be the best tool for you and what's going to help you the most and understanding what all your options are. So thank you for that. That's a great question. Another question, how is the mini sleeve different from the gastric sleeve? So the mini sleeve is the laparoscopic gastric sleeve takes away about 75 to 80% of the stomach. Your stomach, like we said before, it goes from that large bag down to a small tube. That extra stuff comes out and it gets a lot smaller. The mini sleeve just takes off less stomach. So your stomach is, instead of 70 to 80% smaller, it's about 40 to 50% smaller. This is not an operation that we offer at Eviva. This is not an operation I don't see us ever offering either, for reasons that we see people that come back with mini sleeves or that have too big of sleeves, and it really impedes their weight loss. And it can be, some patients can feel like this is like a not quite jumping into the pool, head first, and they're like, oh, at least it's something. Sure, I guess. I would honestly encourage those people that are really hesitant about the whole full sleeve to get an ESG. ESG, I think, is going to get better results in a mini sleeve, more consistent results in a mini sleeve. So the mini sleeve is just something that I think we see people that get mini sleeves, or just that their stomachs were too big with their sleeve in general, and they actually really struggle from a weight loss perspective. They really don't make the progress that they think they're going to make. I mean, this can potentially be a good tool for some people out there. I'm sure there's some people out there that have succeeded, no doubt. But as a general tool from a public health standpoint, I always think of these things in the sense of like, you got this big group of people that need help. you want to have tools that are going to help them be the most successful with the most amount of people. And I would say the laparoscopic sleeve is going to help the most people. The endoscopic sleeve is going to help the next most people. This mini sleeve will probably help some people. I don't have data on that. I'm not speaking from data here, but that's not something that we technically do, just because we see when people get mini sleeves in there, you know, not as good. So, great question. Yeah, there's a lot of information, a lot of things that are confusing out there. But the mini sleeve is not something that we really offer and recommend at our practice. Okay, got some other questions that came in before, which is not necessarily as much of a question, but can you talk about anesthesia? Because I'm really nervous about the anesthesia piece. So, the anesthesia at our surgery, let's talk about that one first. So like we said before, we do surgery in the outpatient surgery setting for many of our patients. And that is where we have a surgery center. We control the operating room. We control the team there, including the anesthesiologists that are there. And they've been doing this for a very long time as well, 15 to 20 years. And they've got some great anesthesiologists that do a really great job. We're really proud of the work that they do. We're really proud of teaming with them and get through patients through very safely. Knock on wood. Our safety profile beats the national average by quite a bit. And we submit all of our data from our surgery center to a center of to the National Society. We are one of the few centers of excellence in the ambulatory outpatient setting. Only 16 of those in the whole country. We are one of them, and our anesthesiologists do a really good job. And I think that just works really well with our team, works well with our surgeons, and get patients through with whatever they have. Knock on wood, we haven't had a really good run of patients doing well. If we do your case at the surgery at the hospital, our anesthesiologists are there from a bigger group, but they're still very good. We work with a lot of those people for a long time. Anesthesiologist I worked with last time I was at the hospital, she's been working with our bariatric group actually for the last 20 years off and on at the hospital. And they do a good job too. And I had a lot of great comments. The anesthesiologist I had before, several of the patients actually said he did such a great job. I passed on the compliment to the anesthesia boss there. And there's a lot of really great anesthesiologists. Anesthesia has come a long ways. It's very safe now, and it's always a concern, right? Whenever you kind of lose control of something, I completely understand that, but the level of professionalism the people we work with have and their skill is fantastic, and I have no qualms about offering these services to anyone in my own family or my own life. And I feel like because they're in fantastic hands. So, all right, getting blown up here about questions on surgery here. Some more. Let's got a couple more I wanted to work through here. When can I get back to exercise? So back to exercise, usually about 7 to 10 days with an endoscopic sleeve gastroplasty, you're feeling good. We have 3 criteria usually we will recommend for people before they get back to exercise. So that is, you have to be drinking 60 fluid ounces of fluid. You have to have 60 grams of protein a day at least that you're getting in, and you have to be feeling good, like good energy. When you're feeling that, and you're like, yeah, I'm ready to go. When you've got all 3 of those in place, you are ready to go. We tell people, take it easy after that first week back. You are not trying to be a hero. Pushing your body to its limit does not benefit you. Your body's healing on the inside. Give it some space to heal. Just kind of get back into your routine. So go about 50% on that first week back. The endoscopic sleeve is usually about 10 to 20 days when people start getting back into some sort of, exercise or a little bit more strenuous activity. But generally people just really bounce back from these surgeries really well. And usually by about 4 to 6 weeks, people say that they are living their best lives. So, all right, great questions here. Got a few more here I got to answer from the text line. All right. Is there a way to combat hair loss? Great question. So hair loss can be a part of any weight loss journey, like especially rapid weight loss journey. And that's a sign of your body being under stress and it's kind of rationing its resources. The ways that we know we feel, I'm going to say feel because we don't have a lot of hard data on this, saying that one thing is better than another. But the recommendations I'm about to give you are universally never bad. So that is making sure you're getting in your adequate protein numbers that we recommend to you for whatever phase you're in. Making sure that your iron supplementation is good and that you're healthy there. You can take a biotin supplement. That never hurts anything. The only downside about biotin is if you're taking it excessively, which we don't recommend, it can interfere with some of your labs and throw some of your labs off as just artificial marker of how the way those labs are tested doesn't actually probably throw them off in real life. And making sure, and that those are generally the things that we think that you can do for hair loss. We'll say the vast majority of patients that lose some hair, or their hair thins while they're going through that particularly strong, fast weight loss process, that hair does come back once their body kind of stabilizes and they get more on to a stable like weight, you know, where their kind of weight thermostat sort of equalizes out. Generally, patients, their hair comes back, it starts regrowing. And even the patients that have had a little bit thinner hair afterwards, I've never had someone say, I wish I had my hair back and I had my obesity back. Yeah. So it is kind of distressing, and it sucks when it does happen. But we recommend some things. We work with you, get you through it. So could I speak? So which surgery is best for diabetes? Excellent question. So there are let's take a look at the big four in this case. Medications, the GLP-1s. So these are decent. These are initially used for diabetes treatment. And that's where we started seeing massive weight loss. And their usage their benefit on diabetes is has been shown to probably be primarily from the weight loss piece. Really helpful with that piece. They can be really good tools, but they're not necessarily permanent. They are, they're not treating the base situation. And the next one is the endoscopic sleeve gastroplasty, the ESG. So the ESG definitely helps diabetes. We see in our patients a significant improvement in patients that are on insulin. Most of them are able to get off of it. Patients that have diabetes, most of them either it gets better. About 35% of them actually go into remission, which means that it's completely, they don't need anything and their A1Cs are normal, which is super, super cool. That's probably not as strong as our laparoscopic sleeve data. We are processing our own data right now as we speak, and that's going to talk about how we're doing from a diabetes standpoint. We do anecdotally, and from the rest of the literature, laparoscopic sleeve gastrectomy, sleeve gastrectomy is a great operation for diabetes. The gastric bypass, the laparoscopic gastric bypass, is actually probably a little bit better for diabetes than any of those operations. How much better is hard to parse out. So there's a study, I believe it's Cleveland Clinic, that did a study comparing laparoscopic sleeve gastrectomy and gastric bypass for diabetes resolution. And their conclusion was that people that are on insulin, have been on insulin for about 3 to 5 years, do have about 15% or better resolution of their diabetes with a gastric bypass than with a sleeve gastrectomy. Patients that had not been on insulin for shorter amounts of time than that, or patients that have been on insulin for longer amounts of time than that, did about the same with a sleeve versus a bypass. We believe the reason for this is that it's insulin, the diabetes is all about the pancreas and insulin sensitivity. These surgeries significantly help the insulin sensitivity piece. If your pancreas is able to make enough insulin still, like if it hasn't really been beaten down because you've had diabetes for so long, it's able to make enough insulin, then most patients, that's before 3 to 5 years, those patients generally are able to make enough insulin that their insulin sensitivity comes down significantly with a sleeve or a gastric bypass. And they have a good result with their diabetes. Patients that have been on insulin for more than 3 to 5 years, their pancreas has probably gotten punished for quite a while, and it may not be up to producing enough insulin that the patient needs to survive in their body, and they may need some extra help from that standpoint. We never know this before we do surgery, so those patients don't do the same too, because there's not enough pancreatic reserve to make enough insulin for the patients. But so to sum up that whole thing, if you have had diabetes and are on insulin for 3 to 5 years, a gastric bypass is probably the best option for getting about a little bit better chance of a resolution. If you're sort of out of sight of that window, the laparoscopic sleeve is generally our favorite approach because it's more approachable, it's less complications than with a gastric bypass. Usually more long-term and short-term, but it depends. That's a completely about a conversation with you and your surgeon. The endoscopic sleeve is the next best option if you are not into surgery. If surgery is like, that's not me. That's not where I'm at. Endoscopic sleeve. If you're like no procedures, you may need insulin if you need it, but otherwise a GLP-1 is really a great option. Can be a great option for you. So great question. Hopefully that was a little bit lengthy answer. But all right. Next thing is, can you speak on surgery and nicotine? Yes, great question. So nicotine is a vasoconstrictor. So nicotine decreases the blood flow, particularly to your stomach and your stomach lining. And that's why we really discourage the use of nicotine at the same time as surgery. How is that actually played out in the data when people have studied it? And the way it looks is that if you are getting your nicotine from smoking, that has a lot of extra stuff in it. And your risk of a complication actually goes up significantly if you are smoking at the time of your surgery, including bariatric surgery. If you are getting nicotine patches or nicotine gum, we are not seeing the same level of complications. We're seeing about the same as if you didn't take nicotine, which is very interesting. You wouldn't think that that's necessarily the case. Even in colorectal surgery, where the connections that they make in colorectal surgery, which usually we're not even doing in bariatric surgery, are much more tenuous. They don't have as good a blood supply, much more sensitive to those things, but they actually seem to do just fine. They don't see an increased complication rate. We still think from a best practice, it's best to be off nicotine if you can. But if you're really struggling with that piece, being on a nicotine supplementation is okay. Vaping, we don't really have as much data on. There's not as much stuff out there as far as how you're going to do with vaping, because there's a bunch of extra stuff in vaping as well. So we definitely discourage smoking and also vaping, even though there's not as much data. If you need to do nicotine supplementation, it's going to be okay. We're going to get through it. But ideally, we're off of nicotine in general. So that answers all of those questions. Some great questions. Thanks for turning all these in. And then another question I had come in was sleep studies. So what's the deal with sleep apnea and bariatric surgery? Everyone's always talking about it. So sleep apnea, obstructive sleep apnea, OSA, is a very common condition that's found in patients that are struggling with obesity. So many patients that show up for a bariatric surgery. It's where particularly there's a lot of mass, from adipose and fat tissue in the throat area, in the mouth area, that when you relax, when you're sleeping, the space sort of collapses and it obstructs. That's the obstructing part of the sleep apnea while you're sleeping, and it prevents you from breathing. You get the buildup of carbon dioxide in your bloodstream. You kind of get desensitized to some of those things. And so it puts you at risk for, if you have severe sleep apnea or even moderately severe sleep apnea, particularly severe sleep apnea, your risk of a complication does go up with surgery. We have moved to using not very strong narcotics. We found that we don't generally need them for our surgeries. I talked to a lady today. She used one tramadol, which is not a diet narcotic, if you will, after surgery. So we've been working really hard on our operation to try to make it much more comfortable so patients don't need to have strong pain medication. And it's a lot safer to not be on strong narcotic medication, especially if you have sleep apnea. But as a best practice, it really is best to get it tested for sleep apnea. Sometimes having that sleep apnea diagnosis is actually required for your insurance. So this whole process is meant to help you really live the best, get through surgery as smoothly as possible, and also live well. Because if you're not getting enough oxygen while you're sleeping, and you're sleeping 30% of your life and you're significantly depleted on oxygen for that person, you're not going to feel good. Your body's not going to do well. It increases your risk of cardiac complications, all sorts of bad things. And if you get treated for sleep apnea, even before surgery, you can feel way better. I've had people say this CPAP or the treatment is just the best thing that I've done all year. I feel like I'm finally getting a good night's sleep, and everything gets better after if you're not sleep deprived and oxygen deprived while you're sleeping. So yeah, that's most of, I think that's all of our questions. Let's see here, make sure, double check with Chris. Yeah, all right. Looks like we got them all. So thank you everybody for tuning in. Great questions that you've had and filling in. If you are watching this, pre-recorded or recorded later when it's not live, you're welcome to put questions into the comment section. We try to go through those before we do our next question answer, and just see if anyone's added any questions that they'd like addressed at the next one. And then even if you can't make it to watching it live, you'll be able to watch the recap of it. So hit the highlights, if you will. So hope you're all doing well. We're here for you at Eviva, and yeah, if there's anything we can do, please reach out. Put the QR code here on the slide and at evivamd.com, EVIVAMD.com. So great. Hope you have a great day, and thank you again.